Hi, everyone, and welcome for the lecture on Crestal Sinus Elevation, in particular to introduce the novel approach. I am Edgar Chaar, and just a little bit of a brief who I am. I was the former director of the postgraduate program at NYU. I am a periodontist of over 28 years, in private practice also for 25 years. I had a lot of publications, and I have a book, which everything that I'm telling you, it's there. And I am a humble father for 3 children, and I am more than happy to share with you tonight the lecture on the Crestal Sinus Elevation. I like to start my presentations usually with a quote, and I love that quote from William Ward. But the most important part of it is the last sentence: the realist adjusts the sales. And that is a very important in clinical practice, that you will see throughout, that one cannot say that I do only one thing. It will evolve with time, depending on the technology that evolve itself, and then how things have been changing in the whole dental science. So if we look at one of the most prestigious reviews that took place in the Periodontology 2000, they have stated that there is two ways of dealing with the sinus floor. One, it's either by the lateral window approach or with the transalveolar approach. But they stated that transalveolar approach is considered more conservative and less invasive than the conventional lateral approach. And that is true because it's less risk of infections, more controlled, and more predictable. So the way I'm gonna describe with you tonight, we're talking about these different topics. One, first of all, we need to go over the background, and then the paradigm shift into, as I said before, things do change, and the advantages of using piezosurgery, and the complication with Crestal Sinus Elevation, and then we're going to go to the description of the novel technique and share with you some clinical cases. So let's start with the background. In 1994 summers, and I was a young resident at that time. I remember when he presented it at NYU, where I did my training. There was an implant symposium that started by Dennis Tarno back in the day, and Summers himself came and talked about his technique, the Summers technique. What it consistent in reality, it is the elevation and the condensation of the bone through the series of different osteotomes. And as you can imagine, doing it from scratch with an osteotome, it's very invasive on the patient. And with time, Lazara, who is the gentleman who created at that time the implant 3i, came up with a combination of the drilling and the osteotome and the placement of an implant at the same time. And the way he proposed it is that you prepare for short of the floor by doing the sequence of implant preparation, the implant that you are going to use. And then at that time, when you are ready, you break the floor of the sinus by putting bone, and then that can hamper down or reduce the amount of the green stick fracture. And you can achieve two things. One is an elevation, and two, the condensation. So with that, you can see that you can place an implant, you can increase the height of the implant, and then you place your implant. So this took off, and it became more of a common procedure done by a lot of clinicians over the years. But when we look at the search on the PubMed, you can see that there is not a lot of papers written, and mainly in the 2000 that we had the biggest amount. But when we look at all the studies, and I took the time to summarize them for you, and with a long-term as well as the success rate, you can see that only one had the lowest success rate, and that was winter 2002, because they started with an initial height that was very limited, which is a 2.9. So this will lead us, which we can see, the minimum amount of bone that necessary in order for you to do that crestal sinus elevation. And when we look at the short term and the long term of success rate of the short implants using the osteotome technique, we can see that it is similar to that they are conventionally placed in partially edentulous patients. I misspoke with the short, it's not short, but any implant that is placed with the sinus, crestal sinus elevation, compare exactly to the conventionally placed implant in the partially edentulous maxilla. So that brings me to the point that I mentioned before, which is that literature combination that I told you, and where winter 2002, he had a low success rate because of the initial height, and that was substantiated and supported by Rosen and collaborators, that in order for you to have a successful, you need to have a 5 millimeter height. Well, that's also was the 90s. Again, the implant surfaces have changed since, and the technologies have changed since, and one can go down to 4 millimeter and be with the safe side. Now, below the 4 and close to the 3, I caution you on doing the crestal sinus, because the chances are very limited that you can get a good success story. So that's why limiting yourself between 4 and 5, it is a safe zone to be able to do a successful crestal sinus elevation. And that will lead us to the further down, which when we talk about the paradigm shift in the dental science. So let's see some cases that I have done over the years, and you can see how we evolved ourselves. You know, we evolved with the way that we use the implant, the sizes of the implant, and so on and so forth. And you can see here in that case, we are dealing with the maxilla, where you have, depending on where you are as a listener, for the United States, this is number 4 and 5, 3, 4, 5. And if you are in Europe, it is the 14, 15, 16. So we look at the case, and you can see here the extraction of the premolar, the second premolar is lost, and the first premolar needed to be extracted, and we needed to place 2 implants, one in an immediate fashion, one in a healed site. And here, as you can see with this picture, the preparation of the floor, because of the premolar that has a closeness to the sinus here, I combined a crestal sinus elevation with the immediate implant placement. Implant was placed, and just to give you a brief, this is a very old case. I don't do them like this anymore, but you can show you the evolution of time. And that is important for us, how we take it for granted today with the knowledge that we know. Back when I started doing immediate implants, which was the late 90s and beginning of the 2000, and which led me to publish a paper on that in 2011 that was published but was accepted for publication in 2008. We used to live in the concept that you need to fill the whole socket when you place an implant, which later on turned to be wrong. And we need to have a minimum of 2 millimeter between the body of the implant and the socket. As you can see here, I placed a 4.7 to fill in the socket. I wouldn't do that anymore. 2, we know that opening a flap now will lead to a resorption. which that was not a concept understood back in the days. And it was proven, and there was a paper by Fickle who did a time with us at NYU when I was at NYU many years ago, and a lovely gentleman from Germany, and he wrote a paper, the flapless versus a flap extraction socket. And we know for a fact by all the papers that we don't do anymore with flap. So nevertheless, it's nice to see the evolution, and that's why I like to show this case, because you will see the concepts that we said, how it healed when you do second stage. You will see the differences. But here, let's talk about the Crestal Sinus Elevation. As you can see it here in both sides. And this is the second implant placed in the position of the second premolar. And here at that time, we filled in the gap. I filled in the gap with the xenograft at the time. So that's a very old case because I have not used xenograft from the early 2000s to now. And if you know me or you have seen me, and you will see that I'm an anti-xenograft in today's dentistry. Basically, I am a user of an allograft. And it doesn't matter for me if you are in Europe or not. This is something that it is your duty, if you are European, to push for allograft, because it turns into bone. It doesn't leave you these spicules of bone, which if you have a chance to attend my lectures, I show you 20 years histology of BioOS or whatever, xenograft. It's still covered with bone, but it's still there. You put peri-implantitis around it, which is something that we need to deal with in the long term. The bone will resorb, and you'll end up with a foreign body that does not resorb, and that can accelerate and exponentially increase the risk of peri-implantitis. So you close it up, and then you wait for the healing. As you can see, it was done for the two. Again, I want to remind you that this is a evolution. That's why I said the realist will adjust the sales. And that was 7/28/2005. Now, when I did the second stage, I want to show you how much buccal plate has resorbed, and look how the xenograft is coming out, but was grafted into the socket. And that proved the point that we don't do flap, proved the point that you don't put the widest body of an implant because you suffocate the blood that comes between it and the buccal plate. And here you can imagine that the risk is high because you have this spicules of xenograft laying out under the flap immediately with exposure to the environment. So these are the two implants, very successful. That was at February 15, 2006, and restored. And 20 years later, actually more than 20 years later, so that's less than 20 years later, you can see we lost the 16 or number 3, but look at the success of those implants and the crestal bone that has been or the apical bone that has been elevated with the crestal sinus, how stable it is over the years. So that brings me to the paradigm shift. And we have a big paradigm shift that took place in dentistry, which is the socket grafting. Again, for the new beginners that in the field, it's important to remind people how it is. In 1993, in the same symposium, 1994, in the same symposium that I told you that I was a young guy and I watched Summers, I watched also Dr. Becker. Dr. Becker published a paper in 1993, and he said that if you graft the socket, you inhibit the healing of the socket. And that put a stop to all socket grafting, which led Dr. Tano at that time to say that you extract the tooth, you wait 2 months, you go back in and you place your implant. The same thing with the ITI, they call it the delayed implant placement. And when we used to open, we used to have this granulation tissue which later on, Cardarapoli in 2003 defined it that this is the woven bone. So having said all of that, in the early 2000s till now, sockets have become socket grafting has become the thing to do on a day in and day out of clinical practice. And I did publish a paper back in 2013 talking about the success of a graft in a socket. Now, you have to understand that sockets are probably the most difficult thing to achieve if you are not talking about a completely enclosed socket, which that led me to the other paper about the map, how to use the sockets. So the socket is more difficult than a sinus because the sinus is contained, sockets are not contained. So you need to understand when to do what to do, but nevertheless, today we are doing more sockets, grafting and socket preservations. And when you do that, especially in the maxilla posterior, you are achieving a 4 to 5 millimeter below the sinus, which brings us back to what Rosen has said, that it can lead us to enough height that we can place an implant. With that, you are eliminating the need to do a lateral sinus elevation. And not only myself, there's multiple papers that talks about exactly what I said, that by grafting the socket in the posterior maxilla, you are leading to less aggressive procedures, such as the lateral sinus elevation. So unless you have a healed ridge with minimum amount of bone of 3 and less, then you have no other choice. But if you are dealing with the case from the get-go by the extraction, you are ethically obliged to do a socket preservation in order for you to eliminate or reduce the pneumatization of the sinus and the volume shrinkage of the sockets, which will lead you to less bone height. But if you do it at the same time, then you are maintaining the volume and the height, and then allowing yourself to place an implant in with the crestal sinus elevation, that's for sure, in the posterior maxilla. So having said and proven that it is done, that paradigm shift, then we have to think about, okay, is this technique or procedure, because the word technique is not really a valid point in dentistry or anything in the healthcare. Let's talk about procedure. Is the procedure called crestal sinus elevation or transalveolar approach is a safe mean? And when we look at what is written in the literature, you can see that multiple very well-renowned lecturer from Schlee to Baldy to Wu, they are all talking about the safety of combining the piezosurgery with the crestal sinus elevation. So the advantages of a piezosurgery are very valid. So now we are combining a tool that is called the piezosurgery with also the transalveolar approach to reduce the amount of complications or to be more efficient in our placement of the implant. So if we use the sinus, the piezosurgery, we are reducing the amount of perforation into the sinus floor. Again, this is very important because there is a second point in the crestal sinus elevation complications is that you can have what we call in English the paroxysmal positional vertigo, which is the patient can have a dislodgement of the crystals in the ear, middle ear, that gives them a dizziness when after the procedure, because the green stick fracture, which is the fracture of the floor of the sinus, can create a lot of vibration, which can dislodge those crystals inside the middle ear, and that can lead to a dizziness, or what we call paroxysmal positional vertigo. And that's why it is very interesting or beneficial to use the piezo technology to reduce the amount of fracture of the floor of the sinus. Now, the osteotomes without the fracture of the floor are not that, how can I say, traumatic and cause this vertigo, because you are breaking the floor. The floor can be sometimes very hard, and that creates a lot of vibration into the skull. So if you are using the piezo to create the perforation, meaning the breaking without perforating the membrane, obviously, then you put the bone inside and you tap it. The bone is a shock absorber of that of the malleting, and that will reduce the amount of vibration inside the skull. So these are the biggest advantages that we need to always remember with it. So having talked about the advantages of using piezo and the complication, there goes both hand in hand, which is the two that I mentioned, which is the perforation, that it's reduced to a 3.8 and the very minimum. And the secondly is the paroxysmal vertigo, which is the most that you can find with this kind of procedure. The rest of hematoma, nasal bleeding is extremely small with the crestal sinus elevation to almost null. But the paroxysmal vertigo, if you don't use something like the piezo to break the floor of the sinus, then you will are running on a higher risk of leading to that. So I covered the advantages of the piezo surgery. I covered for you the complication that comes with the crestal sinus or the transalveolar approach. Now let's move on and describe the technique that I patent. I patent the inserts. The shape and piezo surgery were kind of making it for me and make it available to you as colleagues to use it in your daily clinical aspect. So that is my interest. I am not going to be making a living off of that, but it is it's nice to see that this project that started with me over 17 years ago is come to light and is available now for us as clinicians. So what does it consist of? It consists of two kind of inserts. One insert that is end cutting, and that is an insert that can perforate or break the floor of the sinus. And then there is one that is the side cutting. So you have three sizes for the end cutting, as you can see the diamond as at the end, and there is the side cutting. This is when you finish the breaking and you've done the bone elevation, and then you have to widen that floor in order for you to put the implant, because these goes to 3.2 millimeter, the largest. So if we take the side cutting, the same measurements apply for all of them. So that end part is a 3 millimeter, and you have the first line is at 3 millimeter. Each band is a 0.5 millimeter. So you go from 3 to 4, 4 to 5, 5 to 6, 7 and 8. And the bandwidth is 0.5 millimeter. The diameter of that and the side cutting is 1.9. It has one corresponding to it for the floor breaking of 1.9, goes up to 2.7 and then 3.1. So, and this is again the end cutting, exactly how I described it for you. It was 91927 3.1. First line is 3 millimeter from the end, and each band of the color, black color, is 0.5. It goes up to 8.5, and which is pretty high. And that's if you are at 8 millimeter, you want to place a 10 millimeter implant. Again, that is a call that you have to do as a clinician. The technique starts by preparing the site as you prepare for the diameter of the implant that you're using, up to 1 millimeter below the sinus. This is classic. There is nothing that I have created that is not been, that's been promoted by Lazara back in the day. Now, once that is achieved, as you can see, that's the osteotomy. Now you go with the end cutting of the piezosurgery inserts, and you break the floor of the sinus. Once the floor is broken, now I have to give you tips about that. The piezo, you do not put pressure with it. Two things: if you put pressure, basically you're pushing to the floor, and even if it is made not to break soft tissue, it will, because you are pushing it. Second, you don't want to put pressure because you destroy the insert. So piezo with the diamond is slow, it takes time. So if you are running with a thick bone, then you can resort to using the implant insert, which has like teeth, and it is powerful on cortical bone. So you can combine the two together if you are a piezosurgery user, and this way you reduce the amount of the thickness of the cortical that you can go for the diamond, and you can do it. Again, do not press, you destroy the insert too, you can lead to perforation. So you do that, you open it. Once you open it, now this is what happens. I call it the donut shape. The donut shape is you have the wide, like for instance, you're putting an implant for 4.8, and the widest insert is a 3.1. Now we do that on purpose. I did that on purpose. I don't want you to open the floor to the full diameter. Now, why would I do that? Because once you put the bone inside and you mallet the osteotome to lift the floor, if you mallet it and you can be aggressive with it, it can go like a ball of, like a projectile, and can rip the membrane. By doing this, I am funneling the bone inside. So I'm controlling the pressure that you're putting in and funneling it in. So I'm reducing the pressure that is created by the osteotome, because we as a human, sometimes we get rushed and we start putting too much pressure, it can go as a projectile. So that will reduce the amount of pressure inside to lift the floor of the sinus. So that's what I call the donut shape. Now, once this is used, you can push the bone. Now, which diameter I use? I use the diameter of that piezo that you use. If you are using a 3.1, you have to look at your osteotomes, and you can use the one that is corresponding to it. You're using the Hugh-Freedy, there is a 3.2. I don't know, you can use Summers, there is a 2.7, or whatever one that you are using to achieve your procedure. Now, you do not, and I want to be persistent on that, you do not cross the osteotomy. So if your osteotomy is at 4 millimeter, that osteotome will never cross the 4 millimeter. That is a very important point. You are lifting. And the way I calculate that, each time I put the bone inside, each number corresponds to 0.5 millimeter. So for instance, if I do 4 osteotomes, 4 rounds of bone, and tap them 4 times, that is, half of it is 2 millimeter. That I've increased the height 2 millimeter. So if you are placing it in 8 millimeter and you had 6, that's you're fine. I always like to have more. So always keep in mind that if you are putting every osteotome, every inside that goes up is a 0.5 millimeter. So that is, again, where did I come up with? This is from trial and error, cases over cases, and I came up with that easiness of finding out the amount of height that you are achieving by every osteotomy, of filling of osteotomy. So now we have achieved the height. You can see it. You can see the donut ring, and you see the bone inside. At that time, you come with your end side cutting. You go very, very gently inside. Now, you don't want that vibration of the piezo touching too much the bone, because it can also push it up and perforate. So you have to be very gentle in order for you to remove the side bone, in order for you to create a continuity of the that osteotomy to place your final diameter of implant. As you can see, now we don't have the donut, and now you can place your implant safely inside. So the advantages of the pre-post technique: first, it's allowed the clinician to achieve the same preparation of the osteotomy with speed and efficiency as they are used with their own dental implant system to the needed diameter. Second, eliminate the most important point, eliminating the green stick fracture, which is the fracture of the floor of the sinus. Third, reduce the risk of perforation of the Schneiderian membrane by using the piezo. Again, I reinforce the fact that do not press with the insert that you are using into the floor, because once you break, it goes in very quickly. If you put too much pressure, you can perforate the membrane. And that brings me to the last part of the presentation of today. It's the clinical cases. So let's go through a series of cases that I've done over the years to prove the point to be able to create those inserts. Here I prepared for 1 millimeter short of the sinus. You can see this is a grafted socket. Basically, that's what we've been doing all along. Here you can see the donut shape. You can see the membrane here. It looks bluish, and that is the rim. That is the donut shape. Now you can see it. It's very hard to take pictures like this, but nevertheless, you can see here, I highlighted for you that rim that is inside and creating the donut, which is the hole in the middle. Now we finished the elevation when we cleared that rim of bone all around, and now you place your implant. This is a very old case. Obviously, if you are a Straumann implant placer, you know that this was the oldest fixture mount that stopped in 2007. And you can imagine this is a case that dates over 14 years. And then the implant is placed. And that is a video to illustrate how I do the procedure. So you can see I used to do the guided surgery back when it was really rudimentary. We used to do them ourselves. Before the 3D printing, you get a surgical protocol, and you go ahead and place the implant. So this is following the protocol. You following up the placement. You're gonna prep using the guide, and I'm sorry, the noise is it's tough. You prepare for the depth by the protocol. So here we are learning how to do the guided surgery as well as the Crestal Sinus. You follow the series. If you are a Straumann user, you know that this is the BL. That's the old one. I don't use it anymore. But you go to every sequence with the 3.5 if you are placing a 4.1, or 4.2 if you are placing a 4.8. And again, that's using the Gonisk table. That's something that I'm sure a lot of people never heard of. That was the way that we can mill the guides. This is to prepare the profiling of the implant. And now this is the use of the piezo technique. And this is before my insert was made. I was playing with it, and you break the floor. And again, once the floor is broken back in the tide, I used to think that putting a collet plug inside was helpful. You don't need to do that. Now I perforated the floor of the sinus. Now you start with the osteotomes, and here you can see I shifted to the cortical bone allograft. And after that, you just plug in the bone inside, light pressure to fill in the osteotomy, and then you start the tapping of the bone. So with that, you have seen how it works, and this is the case with 10 years follow-up, and you can see the elevation and how it's well maintained over the years. So another case, it's a more recent case with the inserts that have been made. Here there was a root amputation that was done, and the site was not grafted, but nevertheless now we have a good septum. So I engaged the septum. Here you can see the opening of the floor, and this is with a better angle showing the donut inside. The bone was placed, the rim was removed, and the implant was placed. Whatever remaining of the socket was grafted, and now we have the elevation. And this is the final follow-up of 3 years of that implant placement. You can see the amount of elevation and the well condensation of the bone over that implant. And that's another one, also a root amputation. That was a treatment of a class 3 FIRCA, extracted the tooth. Here you can see it very nicely, the image with breaking of the floor with the rim, that's the donut. And now you put the bone inside, and then you clear up that rim, and you graft the remaining part of the socket, and that is the implant in place. And the case has been restored and in function for many years. And that will lead me to the last part, also to show you a long term with my technique. This is also to show you how old this case is. I am a original user of the co-diagnostic from the inception, and that goes back to 2010. That it landed in the United States. That was the version 8.0. If you are familiar with co-diagnostic, is one of the best implant software out there. I have nothing to do with them. I don't gain any royalty from that. I'm just telling you what I do. And you'll see later on, I have a YouTube and podcast. If you want to learn how to use it, I have put for everybody to learn, because it's hard to learn if you don't know it. So this is before the era of intraoral scanning and the 3D printing. I designed the guide for the 2 implants, and sure enough, we go, and you can see that it took me a long time to come with that procedure. It didn't happen overnight. I have done it, played with it, made the concept, went to patented, and it took me 11 years to get the patent. But regardless, this is something that everybody can use. Now, I use this case because it's a learning case. It's a long-term case, but also a learning case, because this is, as I said, this is an old case. The soft tissue, I wouldn't do a flapless now that I have lack of keratinized tissue. I would do a small U shape. I urge you to look into my book, Practical in Periodontics and Implant Dentistry by Wiley. There is a wonderful chapter about soft tissue management around natural teeth and around implants. And you can see how I do a very simple management of the flap. I call it the U-shaped flap. And the elevation were done, completed, and the implant were placed, screw retained. The interesting part that is the premolar here was done also as an immediate, and you can see it was not done guided at that time, and it led to a cemented versus the guided was screw retained. So that's why I do all my immediates with the guided. I've been doing this for 29 years, and I know I can do my implants with my eyes closed, but I can get more efficiency. I remove all the unknown. I control my burrs much better if I do guided. So this is a 16 years follow-up, and you can see this is a tissue level implant. It's a very one of the best implants, not very aesthetic, but you can see that the tissue, the lack of soft tissue, can do it over recession. And that's why it's so important to preserve that keratinized tissue around an implant. But I was able to do a follow-up on this case. Obviously, she comes every 3 months in my practice. But I believe I have for you a follow-up of also the CBCT. I needed to do other implants for her, and I took a CBCT, and you can see the nice adaptation of the bone around those implants in the long term with an allograft cortico. You don't need a xenograft, as you've been taught. And you can see the nice results for it for the long term. So with that, I reach my end, and I like to always end it with Chaarisms. After 27 years in education, I think I earned it, that I can give you some advices. One of them is a quote by Yogi Berra. We started with a quote, and I'm going to end it with another quote. Yogi Berra is a baseball player. I have not great interest in baseball, but I love people who have successful careers, and they have made a lot of quotes. He's known for that. He's a barely high school graduate, but he has interesting ones. One of them is very important. I always thought things would stay the same until they changed. And we are very forced with time to learn, to adapt, and to be realistic and adjust ourselves. And that's why I urge you to open your mind and learn about it. Crestal Sinus Elevation is a very simple procedure. It can be very fruitful for you and for your patients. And I hope that you try it. And I like to end it with also telling you how you can get in touch with me. I am on all social media. And also I have a podcast that I'm thankful for the people who listens to it. It has been very successful. We have over 2,000 downloads in less than 2 years. And I have also a YouTube channel. At that point in my life, I want to share all my knowledge with everybody that want to listen to me and come to and learn. I don't care about being paid for these things anymore. So it is a lot of interesting videos on my YouTube if you like to watch it. And with that, I will stop, and I will be here for you for your question and for the questions and the Q&A.